Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
This week, we're absolutely delighted to have Dr. Antonio Caycedo-Marulanda join us on the podcast. Dr. Caycedo is a colorectal surgeon and another contender for the title of the most interesting man in the world. We talked to him about his fascinating life journey, as well as had a masterclass with him on the most common dinner time conversation topic, transanal surgery. Stay tuned till the end of the video where Dr. Caycedo shows us some clips of his own operations and shares his tips and tricks. If you like the podcast, give us a review on iTunes and subscribe to us on our YouTube channel at Cold Steel Surgery. Thank you so much for joining us on the Cold Steel Podcast. It's an absolute pleasure to have you on the show as a true innovator and someone who's just had an absolutely fascinating life journey. Tell us a little bit about where you grew up and where you did your training.
Okay, well, first, thank you for having me and for inviting me to this. I'm originally from Colombia, and I did my med school. I'm from a very small town here in Colombia. I went to Bogota, did my high school there. Then I went to do my med school in Colombia. You go straight from high school to university. So I finished medicine at age 23. Subsequently, I did a compulsory social service, which is for 1 year, then went to do residency for 4 years. I was able to work for about 18, 20 months here. At that point, my wife and I had decided to immigrate to Canada. I wasn't really sure if that was feasible or not. Fortunately, things worked out well. And in 2004, I went to Canada. I landed in Montreal and started doing all the exams, the MCC and all that. And after 2.5 years, I started residency again in Ottawa. Instead of doing the 5 years that typically residency is as an IMG and having had previous training, I started as a second-year resident, but I at the end was promoted, so I did 3 years before I did my Royal College and have my certification. After that, I went to London, Ontario, to do a clinical fellowship, and that was only 1 year in London.
That's a fascinating voyage. Now you ended up in Sudbury next, and I'm curious. You know, we're going to talk a little bit about a real masterclass here that we're so thrilled to have you walk us through, but. Before we do that, you know, one of the things you're going to talk about, obviously, is the complexity and the volume and the density of the content and the technical requirement and the surgery that you were doing. How did you start that in Sudbury as a smaller center? How was your support? How did your colleagues look at that? What were some of the challenges? Can you walk us through that genesis and that experience?
Yeah, so this is a bunch of different steps that happen. So I'll go back a little bit. As an IMG, you have to do a return of service. That's 5 years. The expectation of the government is you're going to remain in a place forever, because statistically, after 5 years in a place, you don't leave. And usually those are underserved areas in which there are some limitations in terms of resources, in terms of the things that you can do. I started looking at where to go. Every other place was significantly small, but Sudbury was large enough, was a regional hospital, was a tertiary hospital that have a large area of influence, but was pretty much just general surgery. Pure general surgery. So I started looking at that, and I remember at that time people in London saying, or other people saying to me, why are you going to go to Sudbury? There is nothing. And the interesting thing is, every person that I asked, have you ever been to Sudbury? None of them had been to Sudbury. So they had a preconceived idea about this place. I went there. The hospital was great. It was pretty large. Catchment area was over 600,000 patients. and there was no colorectal service at all, nothing. When I did my residency in Ottawa, I had significant challenge because I came to this country and I didn't know how to speak any English at all. So it was kind of like learning on the street. When I did the exams, I didn't know how to read any English. I didn't know absolutely anything. So I had to pretty much use a textbook and a dictionary. So I was reading about 4 pages a day, and I'm talking about 12 hours a day, doing this with the dictionary and the textbook, reading like this. And it was just taking, a lot of time when I did my first exam, and it worked. So I was ecstatic that, things worked out that well. So I kind of like applied the same strategy for the second exam, and it worked. When I did the third one, the LMCC part 2, that was oral, first attempt I failed, but I knew exactly what happened. I understood. So I quickly registered for the second time, and it went well. Then I did the exam for the IMG, and that was called at that point IMG Ontario. And IMG Ontario had about 500 applicants for 5 spots. At the end, they granted 3, 1 in Ottawa, 2 in Toronto. So that was incredibly challenging to accomplish. So I was not, I was not afraid of difficulties. I was very familiar with adversity. So going to Sudbury and finding a place in which the chief of surgery at that point, John Snyder, he was very generous to say, you can develop this in any way we want. And the one thing that I said very clearly is, I don't want to do hernias. I don't want to do breast. I don't want, listen, if I'm here, I'm just going to do colorectal surgery. He said, yeah, definitely do it. Most surgeons opposed to that vision. And most senior surgeons that were there, they were like, we've been doing this thing forever. So you coming here, you have an accent, you're not Canadian, and you're younger than us, why are you going to tell us what to do? So it was a constant, I wouldn't say fight, but it was always resistance, and people were like opposing you. In Sudbury, there was never a colorectal service. So patients, if they wanted or they needed something really specialized, they had to go to Toronto or Ottawa, depending on where they wanted to go. By pretty much just going to meet these surgeons, to meet people, to travel to the communities, to start talking and start looking for new opportunities, bringing MIS, laparoscopic things, saying, you know what, let's decrease our rate of permanent colostomy that was close to 40, 50%, being able to bring it down to under 10%. And people have started noticing that, and even the surgeons, and slowly they started to turn around and they say, okay, well, maybe we should, give the rectal cancer patients to you. And I started having that conversations with them. There was significant challenge and resistance from many different sectors. But when people start seeing kind of like good results, and the support was definitely having a chief of surgery that was very open-minded to allow these things to happen.
I mean, it's worth saying that you were doing, not just laparoscopic colorectal surgery, but you were really doing TATME, which I think it's very defensible to say it's one of the most complex operations that anyone can do in colorectal surgery. Just the approach, the anatomy. How did you work that as a person, without, and I don't, correct me if I'm wrong, but I don't think you had another person with you in Sudbury who was doing TATME. So you really didn't have support per se, or someone else that you could say, hey, what do you think is going on here? Because they wouldn't really know. So how did you approach that, sort of being a single surgeon, approaching a complex case like that? How did you institute something like that? And how did you approach those kind of cases?
So in 2012, I got Sudbury in 2011, and early, I wanted to do TEMS. I was familiar with TEMS, but the cost of the machine was $100,000 capital. So as much as the hospital was very supportive and Joe Schneider was very supportive, I knew they were not going to um, um, buy this machine for me. So I started doing some research and I found that there was a platform called TAMIS, but there was no TAMIS in Canada. So I located the vendor through Apply Medical, and it was a company, different company here in Canada. So I approached, this person said, you know what, we have this platform, but nobody that we have approached wants to use it. Like we went to X number of different colorectal surgeons, but people don't want to use it. You know what, I want to use it. I said, I want to do it. Sure, yeah, okay. So they organized for me to go to Seattle. I met Liz Macklemore and I did a course with her. At that point, I remember they have articulated angulated instruments and for the course. And I said, no, I don't want to use angulated instruments because where I am at, they will not have those instruments. So I want to do it with straight instruments. So in 2012, I came back to Sudbury and our first patient is there. I remember doing that case. It took about 3 hours to do. I used a harmonic, the only time that I had used a harmonic for a TAMIS, but I started doing it and kind of like introduced TAMIS for the first time ever in Canada. So I started doing it, accumulated significant experience, and the obvious next step was to move into TATMA. So I went to Barcelona with Antonio Lacey and I did their course. And they were at that point, there was a big hype on TATMA, probably the beginning of that hype with TATMA. So I went for the course and I was very excited to doing it. I was very familiar already with the platform, but this was probably May, June when I went to Barcelona. So came back, waiting for the correct case to do it. Didn't dare to do any cases. And then I remember this person had a T2 tumor, straight for surgery, no chemo rats, no anything. So they measured this tumor at about 14 centimeters. I repeated the scope and yeah, this is an upper tumor, let's do it. So I did this laparoscopically, everything went really good. The patient stayed a couple of days at the hospital. And few days after, not even a week, I was walking by the hall and the pathologist told me, hey, Antonio, by the way, that case, just wanted to let you know, had complete response. There is nothing in the specimen. And I kept walking, thank you, no, that's great. And immediately I realized, well, this patient never had chemo. The tumor is still there. So, you know, you get into like a panic mode at that point. What do? I called the patient and said, listen, I need you to come back. It was an upper rectal cancer, 14 centimeters. So I was entirely convinced that I had resected this. Patient came back on a Friday. I scoped it and indeed the tumor was still there. So what do? And I admitted a patient and I said, we're going to do a TATME tomorrow. That was a Saturday. Patient came in, we set up the platform. All the section had been already done because I did that on Monday. I put my platform with my suture, boom, 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 disconnected this first TATME that I did. Reconnected, the guy did great. He was very understanding of the situation. You know, it was something that I was forced to do this first TATME. And at that point, I became just kind of like confident. Okay, now we can start doing this. That was the first case. It took about a month to do, and I was starting to pick up lots of volume. You know, at some point I was doing probably about 80 rectal cancers a year. That I was almost dedicated to rectal cancer surgery. So I started developing this, and what I did is I had a nurse that was very motivated, so I involved her into this. She went with me to the conference. I took her always to, like, you know, the training places, to everything. And she was there, I would say, in 95% of the cases. She was at the top and then she was at the bottom with me. Like, she was always doing the camera with me. And there was a retired surgeon, Raymond Gay, who was almost always my assistant. So the three of us were almost always in the room. And we created a system in which, at the end, I think we did over 250 TME cases in Sudbury with this team.
That's an amazing story, and of course, that volume is incredible just to consider, given the complexity and the underlying epidemiology of that disease. I'm curious. You're in Sudbury. This is going, sounds like, very well. You've created this program, and then you're recruited to Queens and end up there, and then subsequently to Orlando. So I guess first of all, congratulations. How has your experience? Yeah, it's wonderful. How has your experience in the U.S. been so far for you? What's your vision for that program, and where do you want to go with it?
Well, definitely it's different. It's different than in Canada, and I can tell you the Canadian healthcare system, despite of what many people say and criticize, is wonderful. It's wonderful the fact that anyone can have access to this in the US. There is always the challenge of the insurance company and what's going. I feel very fortunate about what the organization I am at is offering me, and it's pretty much to build a program from, I wouldn't say from scratch, but Orlando Health didn't really have its own colorectal service. The step of being in Kingston to me was fantastic. It was a great experience. The colleagues that I had there, Sunil Patel and Hugh McDonald. And then I think I was very lucky because I came with this TTM experience, but then I landed in Kingston where, Amir, the volume of robotic surgery is higher than anywhere else in the country. So I was able to then accumulate TTME, robotic surgery, laparoscopic surgery, which all together will be a pretty unique set of skills. So the plan now is to bring that kind of like expertise, and also bring the expertise of having developed the colorectal service in Sudbury from scratch, and take this one forward. What is my goal? Well, I tell you, I never planned that I will be here. I didn't ever, this is not even in the wildest of my dreams. I would have thought that I was going to be recruited to Orlando. I'll tell you, not even in the wildest of my dream, I thought I was going to go to Queens at any point. At some point I wanted to do more than what I was doing in Sudbury, but Sudbury was great for me. I'm very grateful to everything that happened there. The opportunity, because I was given a blank opportunity to say, do whatever you want. So now my ambition with this program is, if I told you I want to get less than make this top world-class program, I will be like that's what I'm looking to do. And I want to, bring things from a different perspective. There is a lot of things that are done, for instance, in the US that are based on seniority. I don't think that's the right way to do it. I think should be based on people that are capable and people that are willing to do things, not because of seniority. So the same way that, I found opportunities for me without having that seniority or without having that Canadian experience, and they were granted to me somehow, I want to be able to create something, because I think that's a very successful method to find talent, to find, great people, and then definitely want to surround by people that I think are better than me, so they can, help me elevate this thing.
We want to dive a little bit deep with you and do a little masterclass here on transanal surgery for obvious reasons. We're going to confine our discussion, if that's okay with you, Dr. Caycedo, to talking about just TAMIS or TEM, so excision of rectal polyps or early rectal cancers from a transanal approach. And just again to define some of these terms, so TAMIS is transanal minimally invasive surgery, and as Dr. Caycedo said, that's a flexible platform that you can put in the anus, and then put some trocars through and use traditional laparoscopic instruments to actually do the operation. Whereas a TEM is a transanal endoscopic microsurgery. That's a more traditional platform where they use a rigid platform that we stick in the anus, and then use the angled instruments that you were talking about before to do this procedure. I think most places now in the world probably have moved towards using a TAMIS platform because, as you said, it's much cheaper and more flexible than than a TEM platform. But I think many places across Canada still, at least where I've trained, they're still using TEM because that was what people kind of started off with. So let's say, Dr. Caycedo, you get a patient who is sent to you with a large rectal polyp or a rectal lesion. What are the things that you look at when you're assessing that lesion that make you think about whether this would be amenable or even appropriate to consider a transanal excision?
Sure. Well, definitely will be that I believe, based on evidence, that this is an early lesion. That is not an ulcerated, clearly fungated cancer that will be within the reach of the platform. That doesn't appear to be fixed to the planes. And if you think it's a polyp or it's an early lesion, then obviously you have to do the staging. Sometimes, we will do the MRI. I think all the times we'll do the MRI if we think it's a malignancy. If it has the appearance of being a polyp, probably the MRI will not be necessary. But I always do endorectal ultrasound, and I learned how to do endorectal ultrasound myself because it's very subjective, the endorectal ultrasound. If and one of the challenges with MRI, you probably know that already, is defining between T1 and T2. The MRI has difficulties doing that. So the TAMIS, the endorectal ultrasound gives you that opportunity. Then when I assess the patient, I always want to know what is the location inside the rectum, if it is posterior, if it is lateral, if it is anterior. And the reason why I want to do this is, one, I want to know the height, and second, I want to know what are the chances of me getting into the peritoneal cavity when I'm doing this. With the TAMS platform that you train under in Vancouver, and we actually did a study in which we pretty much compared the two with Canadian data, and definitely there is no major differences using either or. It all depends on what the resources and the ability of your hospital to have. But anyways, I want to know these type of things. One, it is clear to me where it is located, that it has these features. I decide, I think it's amenable to TAMIS. In some centers, they could have endoscopies that is skillful and will say, let's do an EMR, let's do an ESC, endoscopic submucosal dissection, endoscopic mucosal resection. But in my hands, lesions like this will go for TAMIS. Now, if you look at the textbook, they will say the definition is 3 centimeters, less than 30% of the circumference, that are below the peritoneal reflection. As you go, and I tell you, you can bend those rules, and depending on how much expertise you accumulate, you could do more complex cases, which is the natural trend for any operation. So I've done things that are full circumference, that are definitely above the peritoneal reflection, that you get into the peritoneal cavity. So it all depends on what the indications you get to develop in your center, on what access you have. In Kingston, for instance, you have Rob Bishara, who is an incredibly skillful endoscopist. He's like a magician. And with him, we had established some sort of a meeting or informal tumor board for that. And we will get together and say, what do you think? And decide, let's do it for TAMIS, where this patient should go to you and do ESD.
I think that's a really important point. I think it is worth reiterating what you said, that if you are at all concerned that this is a rectal cancer or even an early rectal cancer, it's important that that whole lesion comes out in one piece, and that it's full thickness, because that might actually be like their definitive surgery, right? And that might actually save them a radical resection. But if it's piecemeal or you're not sure about the margins, that's where the real problems can be. So I think that like you talk about, having that really good relationship with your GI colleagues can be so helpful, and having had these kinds of discussions beforehand, so that there's an agreement or an understanding that if there's a big rectal lesion that would be perhaps better resected surgically through a transanal approach, that they kind of know about that, and will not inadvertently kind of hoop the patient into ultimately needing a radical resection. Um,
If I can add one thing to
yes.
that, I think that's a very, very important point. One is I always tell patients, CaRMS or the local resection, this is the ultimate biopsy. So, we're going to move these, and this could be your definitive resection, or this could indicate us that we are going to need to do more. So they need to understand that. And when we say full thickness, it's full thickness of the muscularis propria, but not full thickness of the mesorectal fat. And the reason is, if this person needs more surgery, you don't want to violate that plane at all. I think that should be really understood for people that do this.
Talk to me a little bit about the height again, because I think that's a really difficult thing for people to figure out, right? And talking specifically about the TAMIS, the gel foam kind of platform, how high can you get with that? And are there any kind of tips and tricks if it's a sort of a higher rectal cancer? Do you use a sort of a measurement like, oh, above 12 centimeters, I won't do this? Or is it more of a subjective thing as to, how straight is the rectum? Where is it with respect to the rectal folds, the body habitus? How do you make that decision?
Well, to me, it's a very, very subjective thing that I always want to scope these patients myself, and I want to know where they are. Like, I want to know exactly, their anterior, posterior. I don't ever do a TAMIS without me scoping the patient before. If you have a TAMIS platform that is about 15 centimeters length and you can, get all the way there, it doesn't really matter. But the TAMIS platform is 4 centimeters in diameter, 4.5 centimeters in length. So the reach that you can get is very limited. The maximum that I've gotten to do something was 20 centimeters, but it was the right patient in which the rectum was kind of like a straight, and he was not really a candidate for anything else because of his other comorbidities. No, but I would say, pretty much 12 centimeters will be the ideal, because there's always going to be the valves and the curves and things like that will limit it. And I remember what I wanted to say. In my opinion, conventional transanal surgery for local excision should be of historical value. And there are people that could argue different, but there is a lot less fragmentation, there is better exposure, that you're serving that patient better. When you're doing this conventional transanal surgery, you are fighting with the light in a hole and you're struggling. And no matter how good you are operating in a tiny hole in which you are the only person who can really see and say, oh yeah, it was a good resection. It will gonna come fragmented and with more likelihood of positive margins. Now, one thing that is important is to know, going to your original question, if it is anterior and you think that you are going to violate into the peritoneal cavity, I always place these patients front. If not, I live in lithotomy. It doesn't really matter what it is, at least with the TAMIS platform. I initially was always putting my lesion at 6 o'clock. So I will put the patient in lateral, the cubitus, prone, supine, depending on that. Then as I gained experience, I realized you don't really need to change. You could do it in either position. But if the lesion is anterior, and I think that I'm going to violate that, I get the patient prone. And the reason for that is when I'm going to close that defect, I don't have the small bowel coming into view.
Yeah, I think that's so critical because you only have to see it once where you're in the peritoneal cavity and everything's flopping into your face to regret that in a hurry.
Yeah.
So let's move a little bit into the sort of some of the more technical details. We've sort of already touched on this a little bit. But you let's say you have the person that you think either this is a early rectal cancer or this is just an advanced polyp, and you've done your endorectal ultrasound. You don't think that this is a T2 cancer. And you're bringing this patient to the operating room. Do you do a bowel prep? Is that something that you do? Just an enema?
No, for all TAMIS, all local excisions, both PTME or TAMIS, I will do a full prep. I was burned before in which, you were doing the TAMIS and it was 9, and then all of a sudden you get a gush of stool and then it messes up everything with the time. It's very challenging because it comes into the insufflation and suction device. It damages it. So I always give him a full valve rep, always.
And you talked a little bit about positioning, but I think as you got more experience, it was reasonable for you to just kind of put the patient or the lesion at any position. But for people starting out early, do you still recommend that people have the lesion kind of sitting at 6 o'clock and put the patient in positioning for that, or do you think it doesn't really matter?
I would say it depends on how you learn to do this and how you train. Like, if you're a fellow and you are in a program in which they're teaching you could do this at any position and you learn to do it that way, why wouldn't you do it that way when you get into your practice? So I think it all depends um, on what you learn and how do you learn to do this. Now, if you are already in practice in a place and you want to do this just because you say, well, it's kind of like nice and sexy, I would not recommend it because this requires volume like everything else. It's like there's always been this discussion about rectal cancer, and I don't think local lesions are different than that. They need to go a place where there is volume, where there is expertise. And going back to my original story about how I started this journey, I was lucky enough to be in a place in which volume was almost a guarantee. It was just a matter of concentrating that volume and prevent the leak of those patients. But doing this, I think, definitely requires volume and consistency.
So you have the patient in position. Um, how do you actually set up your TAMS platform? Are you putting in a Lone Star? What are some tricks so you can actually get things effaced enough that you can get the whole platform in, it doesn't move, and you kind of have the maximum reach?
Yeah, so the TAMS platform, as I said, is 4.5 centimeters in length. So it has sometimes challenges for you to put it. If you're doing this for a female patient that had a very short anal canal, it's pretty easy to put. And what I do before I put them on the start is I always put like the stitches at the four corners, trying to efface the anal canal. So I put a stitch with a tool silk with a big needle, taking the anal verge, then anal margin, and then perineal skin, kind of like to accordion the skin. That, in most cases, is enough for you to bend your platform and introduce it into the anal canal. Then if you are, because you could imagine how this will be on an obese male with very big chicks, it will be very challenging to put that. So I put those stitches. And if I still see, or I know in advance because I know the body habits of the patient, then I will put the Lone Star retractor. Otherwise, you'll be struggling. It will be pretty much impossible to set up that platform in there.
You've talked to me before a little bit about how you actually introduced the TAMS platform itself, in terms of bending it, or remind me again about how you actually, when you put the gel foam in, how you put that.
Yeah, so you take the circumference and you bend it. You create kind of like a notch, and with a Kelly, you grasp that, so you decrease the lumen of that. And then you insert it, and you got to make sure the upper rim is above the elevators. It gets stick there, and that's how you know for sure. Sometimes you put it in there, and it has to have a perfect circle, and when it doesn't, sometimes it's when you use that obturator. That's the time when I use that obturator. If you're gonna try to put this platform straight with this obturator, you're gonna pretty much like hurt this patient, rib tissue, damage the anal canal.
Yeah. And on our YouTube video, I'll put a picture of the platform so people kind of know what we're talking about with respect to the operator, et cetera, et cetera.
I can also send you maybe a couple of pictures of those stitches that I'm talking about at the quadrants, and see how it makes sense to efface the anal canal with those, because it opens up the anal canal.
Absolutely. And is there anything special about, so for people who haven't seen this, this is there's sort of a gel foam port on one side of this TAMS platform, and you actually put the instruments into this gel foam port. It's kind of like, people have also seen the hand assist ports. It's a similar kind of setup where you can actually put the instruments and the ports right through that gel foam kind of membrane. Is there anything special in terms of the way that you actually put those ports in, or is it just a standard kind of triangular formation?
Well, I have my standard, which is to try to put the three ports as far from one another. I put two at the top and one at the bottom. I put my left hand at the bottom, my right hand on the upper corner, and then the camera comes on the left top port. The insufflation device that I use is the air seal, or something that is valveless that prevents the quivering of the rectum. Or you could have now with this platform, there is a reservoir that creates that. So every person, I think, will create its own method. For me to say, oh no, you always have to do it this way, I think it will be wrong. It's just whatever really works for you. For me, what works is I should have this triangular configuration.
You mentioned that in terms of your instruments, you tend not to use an energy device like the harmonic or the ligashare. What's the reason for that, and what kind of instruments do you typically use?
Yeah, I don't use any energy device because I don't think you need it at all. It's not necessary. As I say, the first time I did this, 3 hours, and I use an energy device. You could use it just with regular monopolar cautery. And when you see a vessel, because sometimes you're gonna encounter like vessels that are enlarged, you could use a hot Maryland to do that. And the first thing is to demarcate your lesion before you do anything. You see where it is, and you demarcate it. You put little burning spots to make sure you go that. If you don't do that, you're gonna get lost. It doesn't matter how small the lesion is, you definitely are gonna get lost.
Right. And then when you go about resecting these, what's your approach? You typically, so after, marking out your margins, you typically go sort of proximal on the lesion and then kind of work your way back. You start distally, try to raise it, go work on the sides and then come underneath it, or does it really depend? What's your sort of typical approach for most lesions?
So it's pretty much a combination of everything you said. You got to be frugal. I would like to, if I can, come from proximal to distal, but it's not always possible. Some lesions are too bulky, or they're behind a fold or something like that. That's what I think is very important, to demarcate the lesion in advance. So you do what is feasible, what is possible. There are even situations in which I will say use a hybrid approach. If the lesion is very, very distal, you kind of like have to start open, like it's a conventional transanal. You start, opening your plane very distal. You lift that part of the lesion of the wall, and after you introduce your platform, you continue that way. So it's almost like whatever works. Sometimes you start proximal, sometimes you start distal, sometimes you start open.
Right. And what are you aiming for in terms of thickness? I think you alluded to this before. Do you always try to go full thickness for these, or do you ever go submucosal? Do you ever inject submucosally to try to raise that?
That's a great question. I do not typically will raise, and I will try to go full thickness. You kind of like have an idea that this is not malignant, that this is just a polyp, but many times you don't know. So full thickness of the muscularis. Could you do kind of like an ESD, just go submucosal? Sure, you can. But my preference is to go full thickness.
Right. So, and then the perennial question about the defect. So once you have this lesion out, you've removed it. What do you do with the defect? Are you closing these defects? Are you selectively closing them? Talk to me a little bit about that.
So your teacher and your teachers in Vancouver, and you probably were part of that publication, Carl Brown and their group, they clearly demonstrated to us that there is really no difference. In my experience, the difference is the ones that you don't close have a little bit of a greater tendency to bleed. I try to close all of them. And the reason is they heal faster, but also is good practice for those lesions that are into the peritoneal cavity. Because when you see that into the peritoneal cavity, you get the chills, but you need to be prepared to close that defect no matter what. So having this experience when you don't have instruments that are angulated, you don't have an angle, you are pretty much working in a parallel fashion. So you need to be able to close this. Tying is very complex. So I use some sort of a barb suture that prevents you from having to tie. In the past, I used to place some clips, laprotide made of bifill, but tying is very challenging. If the lesion is very distal or is something that, closing it will narrow the lumen, then those defects I will leave open when they're too extensive to do. And I would recommend that, always close it in a horizontal fashion, never vertical fashion, because that will narrow the lumen, and that definitely is something you don't want to happen.
So let's talk about for a brief second about that scary situation where you clearly can say, "Oh boy, I'm in the peritoneal cavity," and your sphincter is tight, looking at the small bowel flopping into view. Are there any tips and tricks for trying to close that type of defect when you're clearly into the peritoneal cavity? You know that you have to have that closed.
So first, this in most instances shouldn't come as a surprise. You should know in advance that you're likely to get into a peritoneal cavity based on location, and that's why those patients you most likely will have in a prone position, knowing that this will happen. Then, depending on the extent, you will say, I will divide this defect. So I typically try to start from the most difficult corner. I try to define which one is most difficult to get on and see if I can put it there. If I cannot put it, because if I can start with the most difficult corner, let's say at the right upper, then I can put traction and then bring it into view. If I start into the easiest corner, sometimes seeing that one when the defect is closed, in my experience, is more challenging. Or sometimes what I've done in the past is also try to find the middle of the defect and start there and put my first stitch there, close it and divide it, and then do the left side and the right side of that defect. Is viable. Sometimes the defect is not as massive, but it's always going to be larger than you think. You have this lesion that you say, oh, it's 2 centimeters, and then when you see it, the defect is always a lot larger.
That's fantastic. Like on a side note, or I think one thing that we don't often think about is how we send those specimens. And for the pathologist, do you do anything special in terms of pinning out the lesion, just to make sure that those margins that you've so carefully established at the beginning of the case aren't effaced or don't kind of shrivel up when they are put in formalin? Do you pin those out or mark those out? What do you do with the specimen?
I always put it down on a piece of cork and different methods depending on where you are. Before, I used to use that little foam where the nurses discard needles, and I suture it to that. There in Kingston, I was always using the pins on the piece of cork, but you want to do that, otherwise your margins, when it is in formalin, are going to shrink, and your pathologist is going to have a very hard time defining the margins.
So, Dr. Caycedo, when you have this lesion back from the pathologist and they say, that was a wonderful job, Antonio, the margins are all negative, but in fact, there is a focus of an invasive cancer in this specimen. How do you approach that classic malignant polyp in the rectum? What are the things that are the factors that you're looking at that would make you think, maybe this patient needs something more in terms of radical surgery?
Sure. Well, if it is a T1 lesion, you're more likely are happy and convinced that you did sufficient treatment for the patient. As I said before, I always tell patients, this is the ultimate biopsy. If it is more than a T1 lesion, with a T2 or like any concerning features, I bring up the patient and say, we got to do more for you. There are occasions in which you go knowing that this is a more advanced lesion, a T2, even a T3 lesion, but the patient is not a candidate for anything else. So you want to do some sort of local debulking. But anything that is more than a T1 lesion, you want to offer something more radical. Initial studies suggested that a T1 lesion will have a risk of about 10% of having positive lymph nodes. We know now more that risk is significantly less than that. But I always talk to patients, they are people that are 40 years old. You find that the polyp was actually a malignancy, and it all depends on the level of comfort they have. There is a small chance that you might have positive disease, and the patient might tell you, I cannot bear the thought of having a single cancer cell in my body. Let's go for something radical. And you tell them it's very possible that nothing else will be found, but if that is your thought, as long as you understand the functional changes you're going to have, then sure, you go for that. If it is a 70-year-old guy or person that has this very early lesion, you most likely encounter patients that are very comfortable and say, I don't want to give it a second thought, leave me alone. They don't want to go for anything else.
What are the high-risk features that you look for on the pathology report that you care about for T1 cancers? Are there any high-risk features that you care about?
Yeah, I would say pretty much microvascular invasion. It will be EMVI is one of those things that I think are critical. Poor differentiation is a bad thing. You could also argue, depending on what your pathologist is going to tell you, on how deep this is into the submucosa. And, we could get a little bit more complex into defining the depth of the submucosas as 1, 2, and 3 combined with those different aggressive features of poor differentiation, EMBI, lymphovascular invasion, in which you could say, the biology of the lesion is more aggressive, so probably having something a little bit more radical will be necessary. Now, you can recall the CO28 that actually came from Vancouver, and a bunch of hospitals, we participated into that, and it was very promising study, having from T1 to T3 and 0 lesions that receive preoperative chemotherapy. And if they have an adequate response to go for a local excision, that was all with the goal of organ preservation. That's a whole different thing because it was a little bit more experimental. But many of those patients possibly could have had these features there. So there's a lot of things that we need to learn more about the biology because what we do is purely mechanical.
Yeah, so that was the NEO trial that I think Carl Brown, Hagen Kennecke, I think it's now published from ASCO. How do you follow these patients that you've just done a local excision on? How often are you doing endoscopy? Are you doing any kind of imaging to follow these patients?
So let's say we have a T1 lesion that was excised and we are happy and the patient is happy to go that route. I will bring it initially to do flex scopes every 3 months. I will do imaging. Preferentially, I think I would like to do an MRI just to see if there's any new lymph nodes. And taking this very with a grain of salt, information that you're gonna get from there, right? Like if you do it very early, you're gonna find inflammatory changes that could be confusing. So I will do scopes every 3 months. I probably will repeat the imaging at about 6 months to a year, and I typically will not do CA levels or things like that for T1, which are not really recommended. It will be more like an endoscopic and radiologic follow-up. If this is something more advanced, then I will do a more aggressive type of follow-up.
That's fantastic. I'm actually gonna, if it's okay with you, bring up some of your videos that you posted on Twitter. Here's a video that you talk about where you talk about your approach, about how you score. You use regular monopolar cautery. You do a full thickness division. So you talk us through what you're doing in this particular clip.
Yeah, so if you see the lesion has been completely demarcated distally approximately, and now I'm just defining getting into that bright yellow spot is the mesorectum. I want to be as close as I want to the wall, and the reason is I don't want to violate the mesorectum. So here we're going from the distal aspect. Now we're taking more towards the lateral aspect of this lesion. I'm not sure if this was a T1 or it was just a polyp. Possibly it was a malignant polyp. Very careful with the traction that I create to that because I don't want fragmentation. So I grab it very firm, but in a very delicate fashion. So now I'm going there into the fat. Possibly here there was a vessel, I think at the bottom, then you can see it, that you can easily control in most cases with the Maryland. Now you can see it, the defect is much larger than you thought. I always wash it. I review hemostasis. These patients, almost always I send home the same day. I keep the patients that got into the peritoneal cavity. And if you see, I started at a corner there. This is finished. 2 sutures were done. Defect was closed completely. Review hemostasis. The other thing that I would say is what I've seen is if these patients take any type of NSAIDs after, those are the ones that bleed. I don't have any hard data to support that to say, but I tell the patients not to take any ibuprofen, for about 2 weeks or so.
And you're making this look pretty easy, but this is very hard because you really don't have, triangulation at all when you're doing these. Where is your assistant usually standing? They're usually kind of standing to your left side, because you put the camera in the left upper quadrant. Is that right?
Yeah.
Yeah.
So, there are, as I said before, you have no angulation of your instruments. They are parallel to you. Typically, the person will be on the left side. If you have something like a flexible camera, that makes it very easy. But in most places, it's a rigid camera. So I would say having a 30-degree lens will be very useful, and the person holding the camera will be to my left.
Here's, I think, the full video of you closing this defect. You're using a barbed suture. I think that one is a
Yeah.
V-lock.
Correct.
Yeah.
And the thing is, you can put your stitches any way they come. You can put it from inside, outside of the defect. It doesn't really matter. So, here is me closing that defect, going in any direction. You just want to make sure that this is be closed in a continuous fashion. So that is stitch one there that you saw the stitch went through and through the two right there.
Yeah, well, that's where it's nice, where it's easy that you can just take it in one kind of thing, rather than having to try to.
And if you take a look at the left hand is pulling the suture, and that is used to present the tissue to myself. Rather than grabbing the tissue, I'm pulling on the suture.
And you actually use 2 sutures there because it just, what was the thinking behind that in terms of using 2 sutures as opposed to just running that one all the way over to the right, or all the way over to the left rather?
Then one suture will not be sufficient. So I started at one corner. When I got to the middle, I said, well, this is not going to be enough. So let's start at the other corner and try coming to the center. The alternative would have been to start in the center, divide the defect in 2, and then go with one suture to one side, going to the other suture to the other side. The challenge, though, is that the corners are the most difficult parts to see. So it's better to try to start at the corners rather than living to the end.
It's always amazing to me that these patients don't really have more issues with stricture or narrowing, but I think it's very rare, especially when you close it transversely like that, for patients to really have any issues with stricturing or narrowing. I don't know if you've had any problems with that or issues with that.
I don't think that I had any strictures with narrowing so far. With that being said, I've had cases in which I started doing it and I realized this is going to be narrow. So I stopped, I cut the suture and leave the defect open. But I haven't had any patients postoperatively that had a stricture and then they run into problems.
Well, this has been an absolutely fantastic discussion with you today, Dr. Caycedo. Really,
Thank
really
you.
appreciate your time. And I'll just mention for the listeners that you're actually in Colombia right now, helping people, other surgeons out learning TATME and other techniques. So you just keep rolling and keep grinding and pushing. So that's just amazing and inspiring for all of us who are, early on in our career. So thank you again.
Thank you.
If you could go back in time, knowing what you know now, what advice would you give yourself as an early attending or perhaps as a chief resident? Any piece of advice that you give yourself?
Sure. I'll tell you one thing that Eric Poulan, who was the chief surgery in Ottawa, he was a master laparoscopic surgeon. He's no longer this client, but he said to me once, we were doing surgery, I think I was a third-year resident in Ottawa, and he said, just have this in mind. No one is indispensable. No one is absolutely necessary, but just make sure that you become almost indispensable, wherever you go. So I think that's the greatest piece of advice that I have ever received. I always mention that because that is a way just to say you always stay hungry because of that thing. You do things that are going to differentiate what you do from what other people do. Not just to say that you got to be exclusive or anything, but just try to always push the envelope to see what else you could do. Just keep your motivation high, I would say.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you like what you've heard, please leave us a review on iTunes. We love to hear your thoughts, comments, and feedback, so send us an email at podcast.cjs@gmail.com or tweet at us at CanJSurge. Thanks again.